Hello everyone, thank you for joining us for another video today. Today I'm going to talk about spinal cord stimulators and how they could be used to help patients with dealing with a lot of pain. If you're watching this video, likely you have been told by a pain specialist that you might be a candidate for a spinal cord stimulator and you're looking for videos to help inform that decision. Or maybe you've been dealing with a lot of pain for a long period of time and you're really looking for solutions to help get your pain better. So stay tuned in to learn about what a spinal cord stimulator is, what it's used to treat, the most common complications and adverse events, and then what are the long-term evidence and what are the long-term efficacy documented in studies. So what is a spinal cord stimulator? Basically, in a nutshell, it's a medical device that involves a battery that's hooked onto a wire or a lead. That lead rests and lays right next to your spinal cord. Now that wire delivers a low-dose current, and that low-dose current essentially blocks pain signals or dampens the pain signals from the part of your body that's causing you pain from reaching into your spinal cord and into your brain. By dampening that signal, that effectively reduces the amount of pain that the patient perceives from coming from that body part. It does not reverse the pain condition, it does not treat the actual pain condition, it just blocks the pain from being perceived. Contrary to popular belief, spinal cord stimulators have actually been around for quite some time. In fact, the first spinal cord stimulator was implanted back in 1967, so there have been at least several decades worth of research documenting the evidence from spinal cord stimulators. So what medical conditions are spinal cord stimulators used to treat? In the United States, the number one medical condition is something called failed back surgery syndrome. As the name implies, it involves patients who have had at least one or more back surgeries, presumably to treat low back pain and referred or radicular pain symptoms going into their legs. These back surgeries have been offered and they've pursued them in the past, and now unfortunately they are coming back because they're having more pain or they're having unresolved pain. I don't like the term failed back surgery syndrome because it implies that the back surgery was not indicated when it probably was indicated. There's been a push to change that name to something called post-laminectomy pain syndrome. A lot of times patients do experience relief for their symptoms from these back surgeries. However, now their disease might have progressed. Another common condition where spinal stimulators could be helpful is something called refractory angina. This is actually the number one indication in Europe. Refractory angina typically involves chest pain that may or may not be due to prior history of heart attacks. As the name suggests, refractory means persistent pain. So these patients often have had traditional interventions like angioplasty to treat a heart attack or a block in the heart vessels, or they might have had a stent placed in to treat the heart attack, for example. But despite interventions, they continue to have refractory chest pain or refractory angina, and so they might be a candidate for a spinal cord stimulator. Another condition where spinal cord stimulators may be helpful is something called peripheral neuropathy. So what peripheral neuropathy involves is pain symptoms or nerve pain symptoms that presents commonly in the feet or the legs and sometimes in the hands and the arms. Nerve type pain typically involves a stinging, tingling, burning type of pain. There might be some numbness involved. A common condition that presents with peripheral neuropathy is diabetes. Patients who have poorly controlled diabetes or as their diabetes progresses might have something called diabetic peripheral neuropathy. Typically it presents in their feet and then it travels up into their legs. These patients are most commonly on nerve type medications like gabapentin or pregabalin or duloxetine to treat their pain symptoms. However, despite nerve type medications, their pain symptoms continue to progress, and thus they might also be potential candidates for a spinal cord stimulator. Another clinical condition that may benefit from spinal cord stimulators is something called complex regional pain syndrome, or CRPS for short. What CRPS involves is typically somebody who's had a traumatic injury or a nerve injury in their legs or their arms, and despite healing and recovering after that traumatic injury, these patients have persistent pain symptoms. Oftentimes, they have, in addition to pain, they have increased sensitivity just to touch. They might have changes in their blood vessels. They might present with color changes in the area that's affected, sometimes with their skin changing to a blue color. They might also have muscle atrophy where they get very weak and their muscles get much smaller. They might also have changes in the growth of their nails. They might have decreased hair growth. These symptoms are very disturbing and distressing, and despite the nerve injury happening a long time ago, these symptoms may progress, and so spinal cord stimulators are used to treat this as well. Now, there are many other medical conditions that could benefit from spinal cord stimulator therapy, but the ones that are discussed here in this video are the most common ones that are treated and also the ones where most medical evidence exists in the literature. as always, you should visit with a pain specialist who specializes in spinal cord stimulator therapy to decide whether you would be a suitable candidate for spinal cord stimulator therapy based on your medical condition and pain symptoms. So what is the process of getting a spinal cord stimulator? So there are many different steps that have to be performed before a patient is an appropriate candidate. Number one, you have to have a medical condition that can benefit or be treated by a spinal cord stimulator. Now, we've already briefly discussed about that. Number two, the proceduralist has to make sure it's safe to perform a spinal cord stimulator. So if there are certain things called contraindications or certain conditions that will make you a high-risk patient or preclude you from having a spinal cord stimulators, those need to be addressed. And that might even prevent a patient from being a good candidate for a spinal cord stimulator surgery. So for example, if a patient is on blood thinner medications that they can't discontinue, for example, that might make them a poor candidate because that would make them a high-risk patient for bleeding. And the last thing you want is for bleeding to occur in the spinal cord, as that could lead to paralysis. Patients might also have bleeding disorders that might make them a high risk for bleeding. And so those need to be addressed, and that could potentially even prevent a patient from getting a spinal cord stimulator surgery. Another possible contraindication is if there are certain anatomical changes in the spinal cord that might preclude patients from having a lead placed there. So for example, our spinal cord is a cylindrical cord, and surrounding that cylindrical cord is fluid that bathes the spinal cord. Sometimes there are discs in the vertebral bodies that can impinge on the spinal cord. Also, as one ages, arthritis takes over, and arthritis makes bone grow in various ways. Sometimes the bones can actually grow and impinge and compress that diameter that's housing the spinal cord, and that could make that space very tight. So now if you have a spinal cord that has a very tight space, putting a lead in there might be dangerous because now you have very limited space, you have a lead placed in there and that's compressing the spinal cord, and that could cause permanent nerve issues and nerve damage. Also, patients need to get advanced imaging. So what that means is getting an MRI or a CT scan to make sure it's safe to place a spinal cord stimulator. Also, patients are required by many insurance companies to obtain a psychiatric consultation. Now, this might offend a lot of patients. Some patients might say, I don't have a mood disorder, I'm not depressed, I'm not anxious. Why do I need a psychiatric consultation? So this all actually stems back in the literature that has documented that patients who have had mood disorders, typically uncontrolled mood disorders, those are not good candidates for spinal cord stimulators surgery. They need to have their mood disorders treated and addressed appropriately first before getting a spinal cord stimulators, because they might have poor outcomes and achieve poor efficacies from spinal cord stimulators. Because of that evidence, a lot of insurance companies have adopted that as a requirement prior to approving patients for spinal cord stimulator placement. So how's the spinal cord stimulator surgery done? This typically involves two separate processes. First, the patient, after getting approved for a spinal cord stimulator, just comes in for a trial. This is very unique because most surgeries don't have a trial. For example, back surgeries, when you offer it to patients to treat their pain symptoms, there's no trial. You just perform the back surgery. If it works, great. If it doesn't, then we have to look at other options. In spinal cord stimulators, we actually could offer a trial where we just place the wires in the patient. There's nothing else implanted besides the wires laying right next to the spinal cord, and then the battery is essentially just patched on under a dressing, and usually in the back of a patient or in the flank of a patient. And the patient gets sent off typically anywhere from 5 to 7 days, and they test out the spinal cord stimulator. They do things that typically might cause their pain to get worse, and then they evaluate their pain scores over time and their functional scores as well. If their functional scores or pain scores improve typically by 50% or more, different pain practices use different thresholds. But if they see a meaningful difference in their pain symptoms and functional abilities, so if they're able to walk for greater distances, if they're able to do things that they were not able to do before that improves their quality of life, then that's a success. And so then they would be candidates for actually getting the full implant. So after they have a successful trial, they come back for a second surgery. This time, everything's implanted. So the leads that are placed, the whole lead is implanted within the skin. The battery as well is implanted. A lot of times they place it right in the back where the flanks are, where the kidney flanks are, or they might place it in the buttock region. There are different types of anesthetics that are used for spinal cord stimulator surgeries. Most of the times, trials can be done under just local anesthesia, and also most practices also deliver just local anesthesia with some sedation and relaxing medicine given through an IV for patients during the spinal cord stimulator surgeries. we usually tend to avoid giving general anesthesia as most patients tolerate this procedure very well. So what are the different types of spinal cord stimulators that are available? There are many different types of spinal cord stimulators. When we look at types, we're usually talking about different companies and a type of different waveforms or different types of current that are delivered through the leads to lead to pain relief. So the spinal cord stimulator waveform that's been around for the longest is traditional spinal cord stimulation or tonic spinal cord stimulation. When traditional or tonic spinal cord stimulation is delivered to the spinal cord, this often leads patients to feel something called a paresthesia or tingling sensation, and we hope that that tingling sensation is present near the area of pain. So for example, if your pain is located in the front of your thigh, for example, and I place a spinal cord stimulator that delivers traditional or tonic stimulation, I stimulate that lead and you feel paresthesia or tingling sensations in that distribution, then I can say with some certainty that we're covering that region and that it might have a higher chance of giving you pain relief. Other type of stimulation waveforms are also available that are non-paresthesia based or that don't cause a tingling sensation in the area that's causing you pain. Sometimes patients might feel that that tingling sensation is bothersome, and so they may elect to choose these other type of waveforms. There's another stimulation called high frequency stimulation, which, as the name suggests, delivers the waveform in a very high frequency. However, that high frequency is usually not perceived, and patients don't feel paresthesia or tingling in that area that's causing them pain. There's another stimulation modality called burst DR or burst stimulation that is also unique from high frequency or tonic stimulation. And there are other waveforms that continue to be developed in our field that continue to add to our evidence and waveforms that we could offer to patients. Now, getting to the most important part of this video, which most patients are most likely interested in, what are the risks? Are there any adverse events or complications I need to be aware of? Is this safe for me? One risk that most patients are afraid of is paralysis. We are doing a spinal cord stimulator placement right next to the spinal cord. Can there be nerve injury that could lead to paralysis? And the answer is yes. There's a very, very low risk, less than 1%, that paralysis might occur. This might occur as a result of the lead actually damaging the spinal cord, but most frequently it occurs because there might be a bleed after the spinal cord stimulator surgery that impinges and compresses the spinal cord, and that could lead to paralysis. Again, this is a very rare complication, but most patients should be aware of this as a potential complication. Another complication is infection risk. This is particularly important in patients who are immunosuppressed, who take immunosuppressive drugs, who have had prior history of cancer or current history of cancer, who have a history of transplant and are currently having immunosuppressive therapy. These patients, because of the immunosuppressed status, might be a high-risk patient for infection. Infection can occur in any patient, really, even non-immunocompromised patients. And what we're most worried about is a collection of pus that's right next to the spinal cord and that's impinging on the spinal cord and leading to symptoms. Also, sometimes, even without pus, sometimes there can still be infection near the spinal cord in patients with meningitis as well. Another cause that I also mentioned to patients is nerve injury. This is where making sure we have adequate imaging to make sure this is a safe procedure is very important, because we want to make sure there's enough space around the spinal cord to place a lead. However, despite adequate preoperative planning and making sure a spinal cord stimulator is a safe procedure, some patients do experience nerve injury. Another complication that may occur is something called a post-dural puncture headache. Now, what that means is there's a covering around the spinal cord. If the needle that you use to place the lead around the spinal cord, if that needle goes a little too deep, it could cause a hole in that covering. And there's fluid inside that covering that bathes the spinal cord and helps float the spinal cord in the brain. If that fluid leaks out of there, that could cause a lot of tension within the spinal cord structures in the brain, and that could lead to headache symptoms. Usually that resolves on its own, or there are other treatments such as an epidural blood patch that can be used to treat those symptoms. Now, all these complications are extremely rare. Each one of these complications, including bleeding, infection, and nerve injury, are less than 1% each. Now, besides these most worrisome adverse effects and complications, there are other more common and frequent complications. Number one, there could be loss of efficacy or loss of pain relief after getting the spinal cord stimulators placed. Patients may do extremely well with the trial. After getting the spinal cord stimulator implanted, they may do well, very well, for the first 6 months to a year. But there are definitely some patients, after a certain period of time, they may stop experiencing relief from spinal cord stimulators. Now, this might reflect that they're building tolerance to the spinal cord stimulator, or maybe their disease is just progressing and getting worse. So after patients get spinal cord stimulators placed, I do tell them that after a certain period of time, this may stop working and might not be providing them any more pain relief. And so they should do whatever they can, things like physical therapy, to prevent their disease from progressing. Sometimes spinal cord stimulator leads can migrate. If a patient lifts heavy objects, for example, in the near postoperative period, or if they experience a traumatic episode, those leads can move. Even despite a patient adhering to weight restrictions, a lot of times these leads can move. And if they do move, they might not cover the area of the spinal cord that is involved in transmitting those pain signals. This covers the high yield points of a spinal cord stimulator, why you should get them, what are the most common indications, the most common risks. Thank you for joining us in this video. I hope this answers most of your questions.